a 45-year-old patient with a history of imperforate anus and rectal pull-through in the childhood. And she had history of 2 abortion with two unicornuate uterus and ovarian cyst of 8.4 centimeter. So she has undergone laparotomy in childhood for imperforate anus, and she had past history of 3 times operative lab for endometriosis. So now she complains of pain abdomen. So on putting the laparoscope, you can see this uterus is completely covered with the sigmoid and the rectum. So we separated the uterus from the sigmoid and the rectum and did the hysterectomy. So you can see the vault is being opened up. And you have to be very careful while this, because it is very close to the rectum and sigmoid was adherent to the uterus. So the hysterectomy is almost completed. So you need high resolution camera for doing these kind of complicated surgeries. So you can see here that is the sigmoid and the rectum just behind the uterus, totally plastered. So we have already separated it and did the hysterectomy. After the hysterectomy was over, there is a right adnexal mass. So the right adnexa is separated from the adhesions, and what was seen as a cyst in the ultrasound and CT is a pseudoperitoneal cyst. Now we start seeing the pseudoperitoneal cyst hiding in the pouch of Douglas, more on the right side. And this pseudoperitoneal cyst is dissected from the surrounding structures, and she has a big right hydroureter on the right side because of adhesions and compression of the cyst. So you can see, and pseudoperitoneal cyst, it is better to remove the cyst wall. If you just drain the cyst and don't remove the wall, then there is a high chance of recurrence. So you can see that the pseudocyst wall is being removed with dissection after separating from the surrounding structures. And you can see this now right ureter is dissected from the adhesions to release the hydroureter part. So the obstruction is due to repeated surgeries and dense adhesions and the cyst formation. So if you leave these ureters, they will go for chronic renal failure if you don't release the ureter. So it is a good opportunity to release this ureter, and it is a case of endometriosis. So in many cases of endometriosis, the ureters are obstructed, causing hydroureter. So the ureter is released up to its entry into the bladder, and one may put stent or need not put depending on the circumstances. So further, whatever the pseudocyst has to be removed, that is removed again. So the pseudocyst it may not be able to completely remove the pseudocyst, but we must remove as much as possible. And now right oophorectomy is being done, because she has severe pain and so many other problems. So it needs complete clearance. So right ovary is removed, and further adhesions are released. And you can see the rectosigmoid, the endometriotic lesions are excised from the surface of the rectosigmoid. And you can see the ureter on the left side. So all the small bleeders are cauterized so that hemostasis is achieved at the end, and the tissues are removed through the vagina, and now the vault of the vagina is closed with the barbed suture with running sutures.